So I'm going to make it a bit difficult, I'm afraid, for the people that are organizing the questions, because I can see that there are multiple themes. I'm going to try and be smart, and I'm going to try and start at the top and work my way down through the system. So let's start with, I think, a really common concern that people have with acid reflux and the relationship between acid reflux and gastroparesis. And I wonder if I could start with Laurie in terms of advice on food intake, etc., for people who are suffering with gastric reflux.
Right, so gastroparesis, gastro is the stomach, paresis is paralysis. It's not moving the way that it's supposed to, and you don't have control over it. And we can do a whole day on that sometime. I'd like to. And reflux happens because the food has to go somewhere, and it's going up, it's going down. I still like the alginate for a barrier for that if you need it, and you just have to you need food that's going to slide down on its own. So liquid diet, softer foods that the stomach doesn't have to break down on its own is where we go.
Yep. Jim, in your experience, are there any particular medications that are helpful for the reflux and the gastroparesis?
Most people, frankly, get a lot better at just dietary changes. And so I always start with that. But when people have refractory heartburn or reflux, the PPIs like omeprazole are very effective. Many people also have a lot of cramping and bloating, and dicyclomine and some of the anticholinergics are very effective for that. And of course, most people have nausea as well, so they often need Zofran or a medication of that type, anti-nausea agent. And I do like the ginger. I think that really works quite well. It's very effective to get by without a medication. But I think it starts with diet. That really is where it begins.
And in your experience with the antihistamines and their role in gastric reflux, what are your thoughts there?
I like the idea of using medications and diet, but I also want to understand why it's happening in the first place. And it's interesting, I end up talking to patients and I ask them questions like, do you have neck pain or shoulder pain? And they're so accustomed to having the neck pain and shoulder pain that they don't realize that it might be contributing to that neuroimmune axis deviating. And so we've had a lot of individuals who have undergone physical therapy and speech therapy, and also temporomandibular joint issues, which will also refer back to the neck.
Right.
So I think using therapies, and the general rule that I give to most patients, and I tell them to use it with me as well, like, do I have an idea about what's going on and why is it happening? And then what can I give you to help you feel better? So diet and using histamine blockers or protein pump inhibitors, but actually protein pump inhibitors are really not designed to be on for like years, right? And so without problems. So I think doing it temporarily and then also warning you of potential side effects to these therapies. And diet, you need to be careful about making sure you're not compromising your nutrition. Proton pump inhibitors and histamine blockers, first of all, reduce the ability to take care of the biome in your mouth, and also put you at risk for micronutrient deficiencies except for vitamin B12. So we need to make sure we're not getting around that as well. And then after that, like what's the testing? And so what we're doing, this is why it's really important to have a multidiscipline center. We're evaluating the patients for hypermobility issues, because so many people come to me and say, I have mast cell disease. I'm like, okay. Besides me just taking a deep breath also. But it's really important to understand, is the paresis coming because you have a cervical spine issue or an occult tethered cord issue, or you have an immunodeficiency that's unmasked? I think it's really important to figure that out. And then the last question I tell patients to think about themselves is, when are you going to come back and discuss those other four? And so then you have a better idea of not only controlling the symptoms, because that's what we're doing with those therapy recommendations, is like, can we figure out why it's happening in the first place? I have so many people who come through my office complaining about mast cell disease and don't know that they have autonomic dysfunction and don't know that they have a connective tissue issue. So I think it's important to kind of figure out why while we try to help.
Yep. Thank you very much.
If I could add just a comment about that, I think it's important to remember that there are some estimates to put the incidence of mast cell disease as high as 70% in EDS patients. And so one of the very simple things to do with patients like this is to start them on antihistamines like Zyrtec or cetirizine, because a lot of people get better with their GI symptoms and everything else with just that simple measure. And so to echo Dr. Rudin, he said it may not be that hard to treat some of this stuff, and that could be a primary care function. Patients often come in and say, I took a Zyrtec, I felt better, but I wasn't sure if I should keep going. So many of these people need 2 to 4 Zyrtecs a day to really see substantial relief. And so, yes, I agree, pursuing the cause is really important. But these are just some simple steps you can do along the way to improve the patient's function.
Right. Maybe just taking the opposite side of this then, and the side effects of medications, and thinking about whether any of these things can actually exacerbate gastroparesis. So I'll come to you, Jim, and on that one. And then Laurie, just thinking about the changes in the upper gut and the impact that that can have in a negative way on gut flora and the possible risk of SIBO, et cetera, when you change the upper GI. So experience of side effects of medications that can actually exacerbate reflux and gastroparesis.
Well, you know, with EDS and with mast cell people, they often have trouble tolerating a lot of different medications. And so some patients do really well in antihistamines, others don't do so well. Oddly enough, you'd think it would work really well, but some people actually react adversely to that. And so I think the side effects of medications usually are pretty minimal, but I think with antihistamines you have to be careful because it can slow down the gut, particularly if you get on something like hydroxyzine. The things that help control the cramping and bloating, like the dicyclomine Ventol, also slow down the gut. So you have to balance the risk of the medication side effect with the benefit, which may be a lot, but you have to think about the other side of it as well.
Thank you. And any further thoughts on side effects and the GI side of things?
My greatest concern is actually kind of the overuse of proton pump inhibitors.
Right.
Especially when it comes to the bone metabolism, infection, B12 deficiency. You know, and again, those medications were originally designed to only be on for about 6 to 8 weeks. And people are on it for years. So I think it's really important to keep that in consideration. And when it comes to antihistamines, there's a reason why they made third-generation antihistamines like levocetirizine and desloratadine, is because the first generation worked really, really well, but talk about operating under the influence of medications. And then, you know, so you have neurocognitive issues. And then you also have, a lot of these patients end up having Sjogren's. And so here you talk about the dryness effect again. And then lastly, you can actually slow down, as Dr. Harris mentioned, you can slow down the gut itself. So if you're already dealing with constipation issues, you might be aggravating it as well.
So let's go to the consequences of changing the stomach on the small bowel and the large bowel. And there are several questions about SIBO as well, and sort of micronutrient imbalance and microbiome imbalance. Your thoughts there, Laurie?
Was there specific questions or just what?
So I think it's making sure that you've got a healthy stomach so that you have a healthy small bowel.
Right.
And there's several questions on the incidence of SIBO in the management.
And I really think, and I didn't stay on this, if you have SIBO, treat it absolutely, but prevent it, hopefully, is the next step, and that's make that motility happen so that things don't hang around in your small intestine too long. And I do love the ginger artichoke extract for that if it works for you. But then the medications for motility might be helpful as well. Prevent it. Make sure things are moving through there.
Could you share an opinion on the use of probiotics?
Sure. I did the yogurt recipe because I love it if you get your probiotics from fermented foods, if you tolerate them. I certainly will add a probiotic supplement, especially when people have been on an antibiotic. You know that when you take a probiotic supplement, it doesn't build your microbiome, it's there and it goes. It's your ongoing feeding it that help it to maintain. So you need those soluble fibers to do that. But certainly for myself, for other people, sometimes being on a probiotic supplement is really helpful. We are in the infancy stages of research, and there are all these strains that will claim they do this for you, they do that for you. I don't see the evidence that it's always true. It may be a really basic one, lactobacillus is all you need. It may be something else will be a little bit helpful for you, but it's uncertain, I think.
Thank you. Any thoughts on probiotics and also perhaps on diamine oxidase, sort of other supplements that can help?
Yeah.
Right. So diamine oxidase is a little bit easier. And so basically there are individuals that don't make enough of this enzyme that breaks histamine down. But I have to tell you, mast cells kick out a lot of other substances besides histamine. So if you have that deficiency, you might find it beneficial. But please don't keep on investing in that product if you're not seeing any benefit.
Agree.
Secondly,
Or just use it when you're going to drink wine.
tonight, that's a good idea.
Our patients are very clever, very creative.
So, exactly.
I can share.
Good red, I hope. No, I'm just kidding. But I think also it's important. So the data that two of my colleagues and I put forth was we found that 1 out of 5 individuals that came through our office for evaluation for mast cell disease had evidence of immunodeficiency and mast cell dysfunction. And so if you have immunodeficiency, that means you're not having enough antibodies, not enough cells. You might not necessarily have a great biome to start with. And so what we end up doing is we end up doing PCR analysis of respiratory secretions, urinary secretions, as well as stool to see what is sitting there. Mm-hmm. And then we try to address what might be contributing to that dysbiosis, and then tailoring prebiotics and probiotics as needed. And I think we're getting to the point of trying to understand who's living in you. I mean, a lot of us, especially if you have any type of intestinal paresis, you got squatters, and I'm a New Yorker, so I keep my apartment nice and clean, that's great, but my next door neighbor is, something close to, no offense to pigs, but the creatures that are living in that apartment is going to come over to mine. And so I think it's really important to understand that if you have evidence of a connective tissue issue, if you have evidence of mast cell dysfunction, especially in the setting of either allergen-driven mast cell disease, because staph can take advantage of that, and strep can take advantage of that, or immunodeficiency, you're going to end up with an increased balance of organisms that you don't have the resources to get rid of them, and they have no desire to leave because you're providing them with free room and board.
Thank you. So just for those that have asked questions on vascular compression syndromes, I'm deliberately going to ask our team to move those to the session tomorrow, because there is a session on those. Yes. And I wonder if we could now move to, there's a series of questions in here that relate to how on earth you tell the difference between symptomatic gut disorder that is mast cell driven versus irritable bowel syndrome versus inflammatory bowel syndrome. So from a clinical perspective, what are the elements that make you think that it's one or the other? Where would you start?
Well, the symptoms really overlap a lot. So really when you first see a patient, it's pretty hard to tell them apart. There's some testing to help sort that out, but that often isn't very helpful. So what I do is I start with the diet, make sure that they're following a diet that eliminate lactose and gluten and things like that. I recommend the low FODMAP diet a lot as sort of a starting point, although that's not the end point for a lot of people. Right. But if the diet really isn't changing things a lot, then the medications can often help sort some of that out. Antihistamines, oddly enough, will help the gut problems a lot. Many of these people have to go on to something like Chromin, a mast cell stabilizer, or ketotifen. But in the end, you have to just listen to the patient and see what's working for them, what isn't working well, and proceed that way and treat them as the symptoms arise.
Can I ask about celiac disease? It's common in the general population. Your experience of its prevalence within the EDS and HSD community?
Higher. You say no?
I think gluten intolerance is higher.
Okay.
Not necessarily the detection of autoantibodies that help define the celiac diagnosis.
Yeah, Cheryl Harris would here, she would tell us she's got that number. But for crying out loud, please, before you stop eating gluten, please get screened for celiac disease, because the treatment can be a little bit different. And once you've taken gluten out and you feel better, you don't want to put it back in so that you can get the testing.
So, I test everybody for it.
Good.
So I would lean into the first cohort that described mast cell activation syndrome. Actually was a joint effort between gastroenterologists and allergy immunology specialists in Boston. And what they did is they actually went into an IBS clinic and then asked them, by the way, do you have nasal congestion? Have you ever been treated for asthma or anaphylaxis? and they identified from the history individuals that were at risk for having mast cell disease. And they already had the diagnosis of IBS. So then they went ahead and did the appropriate testing to see whether or not they had mast cell dysfunction. And lo and behold, they did. And then they added on the combination of Zantac and Zyrtec at the time. And 100% of the patients reported improvement of their symptoms after being parked in an IBS clinic for 5 to 7 years. As far as IBD, I think, again, I tell patients all the time, I know you don't feel like you're a Maserati, but you are. And you keep on going to a VW dealership. No offense to VW dealerships. So, and I think it's really important that, and the reason why I say that is because it really is a joint effort. You have to have a pit crew captain who can guide you through this really rugged terrain. And then you also have, and then you need to tell the gastroenterologist, I need you to stain for mast cells. Then you need to argue with the pathologist. Yes, I want you to stain for mast cells, and I also want you to see whether or not they have activation markers. Because if you don't use the right stains, you won't see the mast cells. They're like ninjas. So an H&E stain will pick up eosinophilic gastrointestinal disorders. And, but IBD, you're going to see major changes in the epithelial border.
Right.
You know, mast cell disease, looks like, it's a clean and tidy house. And so I think we have to kind of lean into these relationships with other practitioners, pathology, gastroenterology, otolaryngology, dermatology, psychiatry. We all have to come together in order to help people kind of right that ship that got bumped off the road years before.
So we're coming to the end of thank you. Thank you. We're coming to the end of our session with a final question for you all, and it relates to the GI tract being such an important organ, such an important system. When it's playing up, everything else plays up. And there are some questions around inflamed tethered cord, worsening of joint hypermobility and joint instability. I'm just wondering from each of you what your experience is of the gut being the trumping problem that's triggering, masses of other issues.
I don't know if trumping is the right word today, but
okay.
Forgive me.
I'm going to facilitate that by saying you can digest that one in your own time.
Good.
So I think you're right, though.
Thank you. I'm here all week, right? Yeah. I'm biding my time. Okay.
Oh. Thank you.
So, should we do some work now, please? Jim, Jim.
On track.
No, seriously.
On track. No, I think the gut really is the key to a lot of things, because there's no question, until you get the gut under control, many other symptoms are hard to manage. And that includes joint pain and hypermobility, a lot of the issues, the headaches, the migraines, the sleep dysfunction.
Yeah.
The gut really is the key to a lot of that. So work very hard to get that under control. And I will say, while the medications are helpful, I think in the long run, working on the diet, which is usually a 4 to 6 month process, it's not a quick thing to fix, is really the key to getting a lot of these things fixed.
And Dave Knight picked this up as part of the priorities in the very first talk on Wednesday. Sometimes you just have to spot in the history that there's something going wrong that's driving the whole thing. Anne, your thoughts on that?
I'm going to be a bit of a contrarian.
By all means.
I think SARS-CoV-2
That'd be different.
epidemic, I think SARS-CoV-2 epidemic with respiratory health can show you how breathing in something can cause your whole body to go awry. And I think it really unmasked that nerve, epithelial, immune response as well. And so many people, I have so many people who come through my practice and they're like, I'm like, do you have a sleeping issue? Do you always breathe like that? I think respiratory health does not get enough credit.
Right.
And not enough attention, because a lot of times if you can help them breathe a little bit better, sleep a little bit better, that stuff also talks to the gastrointestinal tract. One airway, one GI, one. So I would argue that, again, I like leaning into the GI tract, but I also feel that we need to make a little bit more effort to understand what's going on with that somatosensory input that's happening in the biome in the nose and the back of the throat.
Yeah, thank you, Anne.
Spoken like a true allergist.
Final thoughts from Laurie, your experience
Sure,
of getting it right.
and from where I sit, I worry that if I'm over-focusing on the GI system and on nutrition, that we might be missing something that something structural, something in a different lane. So when I do an initial intake with a new patient, it's at least 2 hours to get a really solid history, and I want to know everything about head to toe. But it is true that sometimes when patients come back a few sessions later and they're feeling better, and I go through the list of symptoms we started with, and symptoms that don't feel GI related may be resolved. And so what do you attribute that to? I don't, it may have been what we did nutritionally. It might be something else they did.
Well, listen, thank you very much. A round of applause for our panel. Really appreciate your expertise.
Thank you.